Good evening, everyone. My name is Ina Zorgo. It's been a pleasure serving as president of TSMA. First, a huge congratulations to all those who matched yesterday. We're so excited for all the great things that you guys have accomplished, 20 plus years of being able to dedicate yourself toward this career. So want to take a moment to recognize all the hard work that you guys have put forth. And today is also a perfect opportunity to gain insight from an incredible mentor, Dr. Wilder. And so we're very excited to welcome her to today's talk, this edition of NextGen series. Today's conversation will give us a glimpse into her journey as a surgeon, as a researcher, as an educator, a leader, and a mother, and provide guidance for all of us as we navigate the pathway from pre-med to medicine and beyond. And so we're all about being able to connect students to inspiring mentors, fostering meaningful leader discussions and the relationships, and being able to support each other during this time. So there's a series of really thoughtful questions that were submitted by over 30 of you guys based on the people who registered for this event. And so we'll just dive into that and also give a few moments for Dr. Wilder to share a little bit more about herself and before we start asking more questions.
Thank you so much for letting me be here, inviting me to be here, and the chance to kind of see you guys and chat with you. I don't know, I guess I can give my general background. My
Yeah.
family, I'm the youngest of five kids. My family is from Nigeria. I was born in New York, but mostly raised between New York and New Jersey and then back and forth to Nigeria. I kind of, I always knew medicine is something I wanted to do, apparently, and spent my high school and college years exploring other things because people said, you should think about other things besides medicine. So I tried and none of it appealed to me. So after doing Teach for America, I ended up getting into medical school. And from there, it was kind of history. I was at Ohio State and then went back to New Jersey for a couple of years for the first couple of years of residency.
Hmm.
And then from there, went to New York for 2 years of research on Memorial Sloan Kettering. And then we went to California because we were expecting our first child, and my husband got a job in California. So it just made the most sense for the family. And then I discovered CT surgery actually not until my third year of residency. So for those of you who know that's something you want to do, this is actually impressive that you know this early because I didn't know until literally my third year. But thankfully, I matched into a fellowship at Johns Hopkins, and then I've been at Brigham as faculty for 4 years. So, almost four. It'll be 4 years in September. So it's crazy how quickly time
Congratulations.
flies. Thank you. I do still feel like I just started sometimes, but I will say nothing is probably the second hardest thing in all of your clinical time is first is intern year and second I think is your first year as an attending. Those 2 years are pretty challenging, but you can do it. So that's it.
Absolutely.
I'm a wife, I'm a mom. We're in Boston. We live south of Boston. I have three daughters. I had all of them, two of them in training and one of them as a new faculty member. So well versed in that struggle as well. So I'm happy
Mhm.
to chat about any or all of that.
Absolutely. Thank you so
Yeah.
much for giving a snippet to your story and your life
Yeah.
and in 2 minutes, basically. And I also want to encourage everyone in the audience to go off mute or to ask questions in the chat. This is a very organic discussion just to learn a little bit more about the pathway. But let's just get started in learning a little bit more about what drew you to thoracic surgery. How did your passion for this kind of evolve over time?
Yeah, it was honestly like when I was on that rotation, I didn't know much about it. So when I was in New York doing my research years, you moonlight, everyone moonlights so you can make some extra money. It
Hmm.
was at NYU actually, and I was taking care of the recovery room, like the post-cardiac surgery cases we were physically in the recovery room, but it was their ICU
I
overnight.
see. Okay. Hmm.
And I was terrified every time I took call because I was just like, this is someone's heart, like what if something goes wrong?
Yeah.
I mean, we weren't alone. Obviously, they had nurse practitioners. They were, people who actually knew the service better. But it was just very intimidating. And even when like people came out with open chests and I'm like, what in the world? Like, that's ridiculous. So I kind of had it in my mind that that wasn't going to be something for me. But then when I transitioned to this new program, in California, we had to do CT. It was like, it wasn't a choice. I think it was a required rotation to spend time on CT surgery. And I remember like the first couple cases I saw, it was a cardiac attending mostly that I worked with. The thoracic guy wasn't that busy. And I was just like, this is cool, like
Mm.
sternotomy, going on bypass, you're stopping their heart and you're starting it again. And what? Like, this is amazing. So I think at some point in one of the cases I expressed my interest, like this is never something I thought I would even have an interest in. And But then I was also like intimidated at that point. I had just had my, sorry, let me try to silence these. I had just had my first child and I was very aware of what the schedule would be as a cardiac surgeon if I what
Yeah.
I chose to do. And so, I mean, this attending had a lot of insight. Surprisingly, he was a middle-aged white male, but he was very like friendly and understanding of my concerns and didn't discourage me. He was like, "Well, you should maybe spend some time with thoracic. You get to still work in the chest, you still get to see what's going on, but the lifestyle's a little bit more reasonable."
Hmm.
So from there, I started to kind of scramble because I realized it was a fourth year match and I was a third year and I had nothing that demonstrated that interest. So that's how I realized STS was going to be in Dallas that year.
Hmm.
Had no money, but one of my attendings was like, I think you just want a scholarship that she personally funded scholarship. So speaking of like people feeding into you and literally being
Yeah.
like, so that allowed me to get to attend. And then I just went up and introduced myself to someone who introduced me to someone else. And then that person was Dr. Cook, who I said, well, I'm in Fresno. Nobody really out there is doing very much specific to thoracic. Can I come shadow you for a week? I used my vacation, went out there and spent the week with him. And by the end of that week, I was like, yeah, this is what I want to do. So,
Hmm.
so he was, a key mentor in that process.
That's beautiful to hear. And it
Yeah.
sounds like you had a lot of pivotal moments, mentors who were able to
Hmm.
speak life into you, people who
Yeah.
sponsored you and spoke your name into rooms. Do you have any advice for students who are pre-med or medical students about being able to foster those kind of relationships or how to seek those out?
Yeah. Uh, Sorry, my daughter is asking me a question. Advice about, so I think part of it is that, for the most part, everybody loves what they do, right? Like it's rare to meet
Hmm.
somebody who's like, I'm just doing this because it's a job. Because medicine is too hard for you to do it just because it's a job. Like you have to have a love of it. And because of that, a lot of people, most people are excited when you meet someone who's like genuinely interested in like the same thing you are and wants to learn more about it. So I say that to say, I think most people would probably be pretty happy, welcoming to have a conversation with you to understand, like to answer questions and to be a mentor to you. Now, I think the challenge is when it becomes an issue of like well, first of all, the geographical differences and trying to get mentorship, even though you don't have anyone locally, I know that can be a challenge. But then
Hmm.
also when some of the same people become mentors, and I think about some of the leaders in our field, like the more senior folks who tend to be like the person you think of when you think of the field, but there's so many people that are doing this, and you don't
Hmm.
necessarily have to get mentorship from that person who is like former president or program director or whatever of all these things because there are lots of people who are in other roles who do this every day that can provide just as excellent mentorship and may have more time. So I think so then with that knowledge, if you see someone doing something that resonates with you, doing work that you find interesting, doing, published a project or whatever that you think is kind of speaks to you, reaching out to that person saying, I saw that you're doing this thing. It really is interesting. Is it possible for me to spend some time with you or talk to you or just set up a Zoom or 30 minutes or whatever? And then when you get on that call or set up that meeting, like have an agenda, say, okay,
Hmm.
the things I want to talk to you about are A, B, and C, advice for getting more publications, how to present myself well on rotations, whatever. So that way you've been intentional about reaching out to these mentors and establishing what your goal is. And then you're demonstrating that you're making good use of both of your times. Because if you recognize they're busy, then you want to make sure that like you're not just kind of showing up like, can you just mentor me? It's like, well, in what way?
Yeah.
There are many
Hmm.
different forms of mentorship whether it's research, clinical, life, all of the above. So I think just being intentional about who you reach out to, being prepared, and then also not being hurt if there's a delay in them getting back to you. If you feel like you have to kind of reach out to them a few times, to kind of say,
Hmm.
hey, I'm just checking in, letting you know. I tell people all the time, send updates every 6 months. Just be like, hey, I just wanted to let you know this is where I am, this is what I'm doing. It's really
Hmm.
helpful because I think it's not because the mentor forgets that you exist or doesn't care what's going on with you. It's just that you get inundated with like all the requirements of, just the clinical practice. So,
Hmm.
yeah.
Yeah. I'll give a pause to see if anyone wants to ask any questions about mentorship before we move on to the next topic or prompt. Okay. What have you found to be the most common misconceptions that people have about a career in cardiothoracic surgery, whether it be in medical school or even college or even looking into residency? Like how has
Mhm.
these misconceptions like kind of evolved over time?
Yeah, I think one definitely the gender difference, like that it's not
Hmm.
friendly to women, which I think it speaks for itself. You can look at WTS, you can look at most training programs, they have a good representation of women. That you can't
Hmm.
do it and have a family, which I think is also not true. And we have enough people that demonstrate that. That I would, let's see, that you have to kind of give up your life or like that it's, well, one, I think when I was coming through, actually, there was this idea of like CT surgery being a dying field. You're not going to be able to get a job. Cardiac surgeons are going to be dinosaurs. Like I still have an attending to this day that calls me a dinosaur. And I'm
Oh
like, well, this
goodness.
dinosaur is doing just fine. So I don't know what you're talking about. We're not a thing. But he's just being ridiculous. But it is a field where there's a need. I don't think that there's ever going to be, I mean, who knows, right? I can't predict the future, but I find it hard to believe there's ever going to be a time when AI or robots or whatever are going to be able to do what we do,
Hmm.
um, and do it well. I obviously don't think that piece is true. I think that medicine in general is something that does require a lot of sacrifice. I was just speaking with someone last week who works on Wall Street and is thinking about making a career change. And I was like, listen, you really have to think about the fact that like this is a 10 to 15-year commitment at minimum. And if you're somebody who doesn't want to be saying no to trips or saying no to certain activities with friends or saying no to, buying a house or, if you're like, I have to live in this part of the country or I have to have this lifestyle, this may not be the path for you because in order to in order to be successful, if you want an academic career, if in order to like meet some of those thresholds or whatever that you set for yourself, there are certain things you're going to have to give up or wait on. And if you're not okay with that, then that's probably a misconception that maybe it's not a misconception. That is one thing I will say is actually like legitimate. Like you really should think about a lot of sacrifice that goes into it. So those are probably the thing. Yeah, those are the main things that come to mind.
Thank you for sharing those. I've gotten some private messages saying how insightful this context is and just being able to share that perspective. I think one thing that I also found to be very interesting about your journey too is your research when it comes to healthcare disparities, especially when it
Mhm.
comes to lung cancer. And I even saw some of the work that you've done on you and lung cancer too. And so
Mhm.
I'd love to hear a little bit more about like what inspired that and how you've been actively working on that front as well too.
Yeah, the lung cancer screening work is mostly the work that I'm doing with Dr. Ryan Hassan here at the Brigham. And what we're trying to do, I mean, the general idea behind it is growing up, I was very well aware of like some people have primary care doctors. Some people go to the dentist every 6 months. I don't know
Hmm.
what that's like, right? Like it was something that for us growing up wasn't necessarily the norm. Some of that is cultural, some of that is access. And then I've also seen, the impact of delayed diagnoses in whatever form and untreated diseases and the fact that like if you can do something about it, why aren't you doing anything about it? Seeing that a lot of it is a mix of things, right? There's knowledge, there's like awareness or lack thereof.
Hmm.
There's a huge cultural piece, and you see how many people it's like, whether it's because of stigma or shame, people are like, I'm not going to a doctor to talk about X, Y, or Z. I'm stressed. I have all these responsibilities. I'm not giving up my cigarettes or whatever it is. And then just the reality of like, I had one plan for my life, it's gone another way. As a result, I'm responsible for all these things or all these people. So speaking like for a parent that's a single parent or someone who's taking care of multiple whether children or
Hmm.
adult caregivers, to like their parents. So people are in all walks of life facing challenges that they didn't expect. And as a result, their healthcare, until it's like an urgent need, falls to the wayside. And I think that the bad pattern, I guess, that exists is as healthcare providers, we kind of are like, we're here, we're the hospital. If you need us, you know where to find us. And I think we kind of have to break out of that and and meet people where they are. So with the lung cancer screening, the idea with that is the mobile units, which is we have this edict that says if you're between these ages, smoke these number of years, you should get a lung cancer screening CT scan. Great. That's wonderful. Your insurance will pay for it. What about all the people who don't know about it? What about the people who know about it but have no way to get there? So
Hmm.
um, transportation and access is one of those things when we think about disparities that we've seen. And the mobile unit, the goal of that is to say, okay, let's bring them out into Muhammad. Let's bring the units to the rural communities, the urban communities. We've looked even within the Boston metro area, the differences in survival based on like living in adjoining cities, not even like Eastern Massachusetts to Western Massachusetts, like West Roxbury, Roxbury, Dorchester to East Bay, like,
Yeah.
or Back Bay. Like, those are things that are scary because it just really drives home the point that, like, where you live impacts all of these elements significantly. So if we can bring this tool to you to provide you the same opportunity to get an early diagnosis, why don't we do that? And then for the other elements, I think similarly, this idea that like we are the physicians, we are in the hospital, um, that's fine, that's great, but our community who we're supposed to be serving for a variety of reasons, is not getting the care they need. And I'm interested in why. So that's where this whole social determinants of health piece comes in. And the
Hmm.
concept that like we should be going out to the community to engage them and say, okay, what are your needs? What are the things that are keeping you from making it to your appointments or from doing the surgery, even though I recommend it, or from taking the
Yeah.
medications, even though I prescribe them? Or even after your diagnosis of lung cancer, what are the things that are making your lung cancer journey harder or really impacting your quality of life so that you don't do as well as your counterpart who has those things? So the work I'm doing right now is really focused on like having this concept of co-design or community-based participatory research, which is that you're designing research with the target of your research as part of the research. So
Mm.
rather than saying, okay, we've come up with this great new intervention, now let's go test it. We're going to sit with the people that are going to be recipients of this intervention and ask them, do you think this is a good idea? Do you think this will help you? Well, if you were to design your perfect intervention, what would it look like? And then design it together and then go test it so that it's informed by the people that are actually going to be using it or benefiting from it.
Yeah.
Because I'm not from these areas. I've never had, thank God, never had lung cancer. So I have no idea if this is a good idea. But by talking to the patients themselves, the hope is that the impact will be more meaningful.
Absolutely. And I think you raised a really good point about being able to lead with curiosity with these questions, is hearing a little bit more about their perspective, their
Mhm.
experiences, what their understanding of all this is, because we come from a point of privilege having all this knowledge,
Yeah.
and have been
Yeah.
reading things in textbooks and been going to working with SPs and things of that nature.
Mhm.
And so being able to sort of work together and figuring out what those interventions are really
Yeah.
empowers the patient to take charge of over their own care and
Yeah.
creates a sense of advocacy, like urgency and
Yeah.
self-autonomy.
Yeah.
Um,
Yeah.
I guess that being said, though, from your experience, what have you found to be the most effective in being able to really try to sort of increase like buy-in from patients and then getting involved in this, just so that we can think
Yeah.
about ways in which we can multiply the impact?
Yeah, I think, I mean, patients can read you. They know if you care, and I think that's
Yeah.
part of it, right? And that's some of the feedback I've gotten. And I've participated in a few focus groups, and it's like, we need to know that you're not just showing up so that you can get, like, is this a transactional relationship or is this actually a
Hmm.
relationship? They can tell when you show up with your consent form, $25 gift card, they know that you don't actually care, right? What happens to them.
Hmm.
Fine, I'll check your check boxes. You give me my gift card, be on your way. As opposed to like, hey, how are you? What's going on with you? I actually want to have a conversation with you. And then I want to follow up with you and come back to this and say, okay, we really, we appreciated the feedback you gave us, and these were the results that we're now sharing with you and asking you what you
Mm.
think about them. So some of those things, like demonstrating to patients that your presence in their community is not just to boost your CV. Like they've talked about like, how many physicians show up and then we never see them again? How many physicians invest in our community for a short time and then they're gone? So kind of building that trust over time and not viewing it as like this timeline, like I need to do this grant in the next 2 years, and then once I get my funding and show that I, helped these people, I can leave. I think that's probably the biggest thing is almost getting rid of your timeline because if you're driven by that, then I think it messes with your intentions.
Yeah.
And I think that's easier said than done, right? Like at you guys' level, you have to be on a timeline. You got to get into residency, you got to match, whatever. But I mean, when you're in your career and you're like, okay, this is my chosen area of research focus, I really need to make sure I'm in this for the right reasons. And I want to get to know these people if this is the community that you're working with and understand what their needs are. And I think, my work is more social needs based and it's more clinical, but this even matters if you want to do clinical trials and you want to make sure that your
Hmm.
clinical trials are representative of the community you're serving. Like, figure out why you have a 95% Caucasian, representation, but then you only have 2% Hispanic and 2% African American. Like, why is there a gap there? And do you actually care that your research represents everybody, or is it that you just want to get your numbers? So those are things that like it goes back to saying, okay, what is really my motivation in doing
Yeah.
this? And then reminding yourself of that as you go along and saying, okay, like, let's go back to the basics of why I'm doing this. And that'll help make sure that your motives are clear as you move forward. So, yeah,
Yeah, they can read you very well. Absolutely. And
very,
I
very
think
well.
being able to partner with people in the community and just being able to be genuine and very authentic and also very proactive with being able to ensure that you're getting this information, but how are you pouring back into them and letting them know what you're using that information for is so,
Exactly.
so very important, being able to complete that
Exactly.
loop basically.
Exactly.
Um, I guess like just thinking ahead in terms of being able to sort of expand this programming and things, this research that you're doing. Do you foresee this being a blueprint for other like areas in terms of screening
Yeah.
and yeah.
That would be amazing. I mean, from the mobile units, we hope that it's something because a part of the struggle has been accreditation and getting a unit that meets the accreditation of a radiologist. There's like the ACR,
I see.
um, who has to approve the unit to say, yes, this meets our standards. And historically, when it comes to research in underserved populations, they're getting things that are substandard. So it's extremely important to us that we can demonstrate that we can do this, meeting the standards to serve populations that are historically underserved and presenting them with the same quality of care that everybody else gets. So if we show that we can do it, then people can do it elsewhere, across the country, and we can show like this is reproducible. And then from the
Hmm.
co-design standpoint, the goal would be to create almost like a what is it called? Like a coordinated care model or something,
Hmm.
where once we get patients in who have a diagnosis of lung cancer, we can identify their social needs, identify the interventions that they need, and have them on a
Hmm.
pathway where their clinical care is being met from a lung cancer standpoint, but also taking care of their social needs so that one doesn't negatively impact the other. So
Yeah. That's phenomenal. It's really great. I hope that everyone's taking notes about how they can start their own programs and research projects and apply for grants and when they get into spaces where they're able to pour back in the community in this way. I kind of want to pivot a little bit more into like to
mhm,
leadership. You hold so many
mhm.
different roles in so many different places, whether it be for STS or even within your own institution. How do you approach leadership and what makes you an effective leader in the areas that you are able to rise?
I don't know that I ever chose leadership, to be honest. Like, I think it's something that's been kind of thrust upon me, not in a negative way, just wherever you train really does have an impact of what you end up doing. So when I decided I wanted to do thoracic surgery, like I said, I was at an institution where we really didn't have much exposure. So I was like, well, how the heck am I going to meet people and get to know what's going on in the field? So at that
Hmm.
point, I don't know if I discovered it on my own or someone recommended TSRA. So I got involved in TSRA. And then I was like, sure, I'll shoot my shot. I'll try to apply for the executive committee or the e-board or whatever. It was just like the
Hmm.
committee, not like
Yeah.
an official title. So I think being a woman and I think being African American probably helped my chances, because like they didn't have anybody else on at that time.
Hmm.
So I got onto that committee, and then with that, there were opportunities for like contributing to book chapters and organizing a webinar and da da da. So I was like, sure, I'll volunteer for that. So then that
Hmm.
led to a couple other things. And then I was also at Johns Hopkins where Steve Yang is, and he was TSDA president and blah blah blah. So and I did Teach for America for 2 years, and he loves education. So like opportunities for things related to teaching and education came up, and I was like, sure, why not?
Hmm.
Because again, your mentors really impact kind of what you do. And then I was volunteered to be like the STS, now it's Inclusion and Belonging, used to be the DI workforce. I was volunteered for that, so I stuck around with that. And then because Bob Higgins was the president at Brigham, no, he was the chair at Johns Hopkins when I was there. And then
Okay.
in terms of the job I have now, he had moved to Brigham and he was like, hey, there's a job. You really should look at it. So he was the one that connected me with the ABCTS. Like he like
Got it.
volunteered my name. So when those things come your way, you're just kind of like, well, I'm not going to say no because back to the mentorship thing, right? Like when somebody's mentoring you and they see something in you and they put your name up for something, your responsibility. Obviously, you can say no, but generally the advice is as a junior person, if you're thinking you're academically minded, you like research, you like to be engaged in that way, um, it's important that you really are selective about when you say no. Because I would never be a proponent of saying yes to everything. I don't think it's healthy for us. But,
Hmm.
so in your early years, you want to be selective about when you say no and really be like, this is why I'm saying no. But if another opportunity comes, I will take it. And you want to make sure that when you take the role, you can do a good job of it so that you reflect well on your mentors. Because in the future, then when they're putting your name up for stuff, hopefully
Yeah.
you're not like embarrassing them.
Hmm.
So I think those pieces are kind of how the leadership thing came about. Then the WTS, I don't know. I think I was like on the scholarship committee for that. And then I was same thing. I was like, in that case, I did volunteer. So that the WTS and the TSRA are the two that I put my name out for. And then the other things came along as like someone recommending me, which I obviously
Mm.
appreciate.
Got it. Let's see. I'm seeing a question in the chat here. So, for international medical students interested in CT surgery, what specific programs, research opportunities, or observership pathways would you recommend
Yeah,
for pursuing during medical school?
that is a very good question. I think that, you know, so he's a medical student, but are you in, and I'm assuming Ivan is a he, forgive me if I'm wrong. Um, I'm assuming Ivan, are you in medical school in the United States or you graduated from medical school internationally? Because I think that makes a difference.
Hi, I'm a graduate. I'm a third year in Russian medical school right now.
Okay.
And I'm
Okay.
going to end Russian medical school in 4 years.
Okay. And 4 years
Yeah.
ending. So I think the challenge is a lot of the grants and research scholarship opportunities do say you have to be like a US trained whatever. So I think in that regard, I would say a couple of things. One way would be to try to get one of the international research scholarships where you come here and do dedicated time, like a year or two in the United States. Because then you're here, you're at an institution, you're fostering relationships with, US surgeons. And then excuse me, when it's time to apply for stuff, you're already in the US, you can say, I'm a US trained research, whatever person. And it allows you to have that on your CV. And then the people you're working with can write you letters. Another option would be some of the international societies. There's ESTS, there's IASLC. I don't know from a
Hmm.
cardiac standpoint. I'm not as familiar with cardiac. But look at some of the European societies and see if they have opportunities for like you can kind of maybe come to the US to train as part of one of their scholarships. Because that's another way to say, okay, I'm going to get the exposure to the institutions in the US without having to match into a program there. Observerships, I've learned, are hard in the sense that institutions have all these rules. I know the Brigham has a ton of rules that I wasn't aware of. I was like, oh, come one, come all. Like all the med students come shadow and hang out in the OR. But for legal reasons, for institutional reasons, they can't do that. So there's all this paperwork and clearances that have to be completed in order for someone to come observe. So I think if you know you want to do an observership somewhere, it's a matter of planning ahead, reaching out to the person you want to work with and asking them if you can come and then figure out what is the pathway. If you're going to do an observership and it's not in a scholarship, you have to know like how are you going to fund it? Are you going to pay for your own ticket? Where are you going to stay? Like all of those things need to be kind of factored out, especially if you're coming just for an observership. So that's why I would say getting a research scholarship, getting some sort of society funding. You
Mhm.
can try through AATS, you can try through STS. Some of the, I don't know. Yeah, I think some of like the smaller societies like STSA and stuff do require you to be US. But then some of the internationals, I would use those and see if any of them provide opportunities to come here.
I see. Thank you. I became a member of STS a couple of weeks ago
Uh-huh.
when I visit US for a
Uh-huh.
conference,
Okay.
and I've been an one observership already in Sloan Kettering. I think
Okay.
the point is now,
Okay.
what is the next step? Because like I've got one first observership, but as I understand for CV, it's not such valuable as some scholarships or summer like summer schools or something like that.
Yeah. So I would say probably look into like some sort of research fellowship. So if AATS, I know AATS does offer research fellowships, like basically something where they fund you for like a year to come here and do, like for example, there's one person I know who came from Nigeria to do I think it's a 2 year research thing with at MGH, the
Mhm.
Yakubian grant or something. So he applied. He wants to do cardiac surgery. He was able to identify a mentor at MGH, and that was awarded. And so he's in the US paid from Nigeria for 2 years. So that's the kind of thing that I would say for you, that would probably be the best option. I think that if that will give you an opportunity to do research and also open doors in terms of mentorship and sponsorship.
I see. Thank you very much. I
You're
see.
welcome.
So glad that you could be a resource in this way, Dr. Wilder. That's
Yeah,
amazing.
my pleasure.
I guess now that we're on this topic, for students who are thinking about applying for CT surgery, I6 programs, general pathway, how do you advise them to prepare early and stay competitive?
For fellowship?
I guess for people who
Okay.
are medical students right now and applying for
Yeah.
residency, I
So
would,
if you're I6 versus
yeah.
traditional, I think, one thing that usually comes up is like, should I do I6? Should I do traditional? I don't think you can go wrong either way. I
Hmm.
will say some caveats. If you know you want to do cardiac historically, and I don't know if I can't speak for all the countries, programs across country. Historically, I6 is more attuned to cardiac. So because you don't spend that much time in general surgery and kind of the people doing the people training you are usually more heavy cardiac. If you know
Hmm.
that you want to do thoracic, or you're like, I'm not actually sure if I want to do cardiac or thoracic, but I really am interested, you can do a traditional pathway. That way, you still get to see uh, general surgery, and then you get your 2 or 3 year fellowship in CT surgery, and then you can decide which path is for you. But then that doesn't close doors for you for for like a general surgery career. So when they look at outcomes in terms of like match rate and operative skills and things like that, there's really no big difference. I just really think, and I advise medical students, or I'm going to try to advise more, if you want to do I6, I would say still keep your options open in terms of apply widely, apply to I6 and apply to general surgery. Don't shoot yourself in the foot by just applying to I6 because I6 is extremely competitive. And it's not a
Hmm.
reflection on you being good enough or not good enough. I will always push for people to believe in themselves. Yes, apply to I6, believe that that's your calling, do it. you just don't know like who else is applying that year. And a lot of times, or we've seen enough instances now where somebody doesn't really heed our advice and only applies to I-6 and then it ends up not matching. So if you're going to make that decision, ask yourself, would I rather match into general surgery and have to go the general surgery traditional path to eventually get to CT surgery, or only say I want to do I-6 and risk not matching and have to reapply? Because if you're willing to accept potentially not matching, then you really have to like be willing to do that. So with all that said, I think the important components are obviously your scores on any exams that you've taken. That's probably the easiest way to open a door. If you're falling in the lower 50th or 10th or whatever, like bottom half percentile, as compared to somebody who has the exact same CV but is in the upper half or higher than that, they're going to get the advantage. And that's something that you know you have to do. Like you have to take your exams. So you might as well prioritize those. Make sure you have a strong score. Unfortunately, that's not enough, right? Like everybody has to study for tests. So how are you going to distinguish yourself? All right. Well, I think at the medical school level, you can demonstrate your unique interests by having one or two things. It doesn't have to be 30, right? One or two things that you're really passionate about that you commit yourself to in your medical school training that say something about your personality. I think those are the ones that speak out to me the most. Like whenever we do end up reviewing applicants,
Hmm.
this person was really driven by the homeless population. So they formed a partnership with this community and they started serving meals every Friday. And now they went from a team of 5 to a team of 50. And now they,
Yeah.
serve meals all across the city, like that kind of thing. It shows like it has
Yeah.
nothing to do with CT surgery, but it shows that you're a person with a heart who has a vision, who sees that vision to completion and also can lead people. Like that says so much more about you than I was on 6 committees. So
Yeah.
I think as you're in medical school, like think about what are the things that make me who I am and like that kind of drive me. Because when you're later in your career, after you've gone through your residency and your fellowship and you just kind of are tired, but then now you get to be an attending and it's like, oh wait, who am I? What are my things? Like you can be like, yeah, this was always something that I was driven by. I didn't have time to do it in fellowship, and now I can go back to it. So that it's beneficial in both ways. So I think finding one or two things that really speak to who you are as a person and highlighting those as part of your training. And if you're going to be involved in it, like be involved and be engaged and like don't just be on committees to say you're on committees. Like that kind of stuff kind of shows. Um, and then from a research standpoint, we understand not everybody's going to be able to do groundbreaking research, right? Not everyone's going to be able to be in the top person's lab or whatever. I think, as you're going through, you're going to get opportunities to participate in stuff. Can you write this abstract? Can you present this poster? This is a cool case. Contribute to this book chapter. Sure, take those opportunities if they come. I'm not saying turn those down,
Hmm.
but as you think about research projects, pick things that are actually engaging to you so that it's not like torture to have to get up and finish this submission and have to like whatever.
Yeah.
Um, you want to show it again, it doesn't have to be in CT surgery per se. You just want to be able to show that you have an academic mind. You can ask a question, you can put the work in to get the answer, and then you can see through to completion. It's easy to talk about ideas, it's easy to put an abstract together, but then getting the abstract from abstract mode to paper and actually getting it published, that also is a show of commitment because a lot of times it falls apart. Once it's presented, you're like, "Ooh, I'm done," And then if you do go through and write the paper, and the first time it's rejected from a journal, you're like, "Well, forget that."
Yeah.
Like sometimes it's multiple revisions. Like I have a research fellow, she left us a year and a half ago, maybe 2 years ago now, because she's in the match process now. And we just got her last paper published. Like literally this week, she texted me and said it's finally published. So that's 2 years later. She's back in residency working on this
Hmm.
thing. So I think if you can show that you can do that as a medical student, that also speaks volumes. So, do you have to have a CV with 30 publications? No. Five, that are really good. If you can be first author, great. If you can be second author, great. That's kind of what you want to shoot for. 10 would be amazing, but a mix of abstracts, posters, and if you can do any podium presentations, that would be great. And obviously, if you can see that through to completion to a paper, that would be great. So your scores, your engagement, your research, and then your letters. So I think as you're meeting people who are providing mentorship to you or clinicians that you're working with in your training, being intentional about the relationships that you form with people and being wise about who you ask for letters from. So when you ask for a letter, you're not just saying, can you write me a letter of recommendation? Can you write me a strong letter of recommendation? Can you write me a good letter of recommendation? Because we've unfortunately seen people write letters for people that aren't very good or very strong. And it's like, well, why would you do this to somebody? Why wouldn't you just tell them like, no, yes, I can, but it wouldn't be a very whatever. So I
Hmm.
think you should be intentional about using your wording carefully. Some people will offer to draft the letter, ask you to draft the letter and then send it to them. Obviously, you can maybe preemptively do that. But I think that, I'm sorry, give me 1 second.
Yeah, of course. Feel free to drop other questions in the chat. You can either put it in the public chat or DM me directly.
Sorry, I was saying good night to my kids. Um, the letters piece, yeah. So it really matters when you have someone who can write you a letter that can speak to you kind of
Hmm.
longitudinally, ideally. So someone who's known you since your first or second year of med school or something. We know that's not always the case. Sometimes it's just a rotation. Sometimes it's just 3 months or even a month or whatever. But
Yeah,
try to like make the most of that time and really demonstrate to them like who you are as a person so that when they write your letter, it actually has some meat to it and they're not just kind of regurgitating your CV because unfortunately that does have to happen sometimes. So I think those are probably the main, like the four main things that I would say is your scores at every level, your engagement in terms of showing what your personality and your passion is in terms of how you spend your extracurricular time, your research, making it meaningful, seeing things through to completion, um, and trying to at least have one or two first authors. And then your letters being as strong as possible and showing like a real relationship between you and your letter writer.
absolutely. These are such huge gems. I hope you guys are all taking notes. Again, the recording will be posted on YouTube. Um,
Yes.
Now,
Well,
yes.
yes, they should be, ideally. If you don't have anyone that can write a letter that's worked with you in clinical setting, that's fine. Like I have seen some letters that are like, we've only done research together, that's fine, but then find someone else that can speak to your clinical side.
Okay, perfect. Any other questions about best tips and tricks for being able to be competitive in CT surgery before we go on to the next question that I see here? Okay. So this is another question that someone sent over to me privately. And so this person is saying that you mentioned that you had your first child during residency, then shortly after you developed an interest in thoracic surgery. They want to learn a little bit more about how your program supported that and how you kind of managed during that period of pregnancy and delivery.
It was hard and overwhelming and all the things that I thought it would be. But yes, the program was amazing. So this is UCSF Fresno. Because at that point I was switching programs. I was kind of like the black sheep, right? In the sense that like I went into the lab for one program, spent
Hmm.
2 years at Memorial Sloan Kettering, and then coming out of the lab, I was like, not only am I expecting, but I also don't plan to come back. And I'm going to show up to this
Oh,
other
wow.
program at I showed up, it was a July 1st start, and my daughter was born August 20th. So like very
Oh, wow.
yeah, so like it was faith, it was like just the way things came together was really a blessing and I'm fortunate that it worked out. Like my co-residents told me like a year later like we hated you when you got here. Which I understand, right? Because it's like how you going to show up 2 years into the program with a baby and immediately go on maternity leave and we don't even know you. So
Oh,
now we're
wow.
best, like we love each other. Like we just, one of them just got engaged, all the other ones have kids. So like we're very much more like family now. But so that transition was very hard. But for me, and I think this goes back to my point earlier about like asking yourself why you're doing what you're doing. For me, it was very much a matter of like, all right, well, I'm starting a family. I'm gonna be in residency, which is already hard. And I'm talking about having my family be miles, thousands of miles apart from each other. Like, that's not, and to me, I was like, yeah, I'm going to ask around to see if there are any third-year positions open in any general surgery residencies in California. I ended up having to take a second-year spot. But if I don't at least ask, then I'll never know. And then I may end up regretting that decision if I don't even try. So for me, it was like, let me try and see. Fortunately, I got into a program where there were multiple women. They didn't, I think maybe only like two or three had kids out of, there were like,
Hmm.
uh, there were at least six women, maybe seven, have trauma heavy department. Only a couple of them had kids, but all very welcoming. Like I have multiple pictures of them holding my kids, like, whatever. So that helped a lot. So even though I knew people weren't happy with me for on the trainee level, I knew I was supported within the program.
That's good.
Personally, mentally, it was hard because my husband was still 4 hours away driving, but at least it was closer. We ended up like that's when I learned that family is not necessarily just blood. Like the woman who ended up taking care of my daughter, she would take her at 5 a.m. I would drop her off when I was on call if I needed to. She would keep her overnight. She would feed her. She would be like, "Hey, can
Wow.
we take Naomi to dinner? Please do. Take her, keep her, whatever." Like I'm
Yeah.
stuck here on call, or like if I was on call, my husband then would go pick her up. She would like force my husband and I to go out on date nights and keep the baby, and she would take like $20 or something like that just to be whatever. So a middle-aged
Mm.
white woman who became like till this day we still FaceTime. Like she's very much family. So I think it also was a lesson in humility and not being like, I got this, I'll do this myself, whatever. Like it wasn't feasible to do that. So it was hard, but it was worth it at the end of the day because like I got to come home to her and now she's 10 and I'm looking at her like, oh wow, we survived, like I didn't kill her.
Yeah.
And she actually like is a good human being. So
Yeah.
I think it's just one of those things where like you have to in that moment say, okay, what matters most to me and what am I willing to do for it?
Absolutely. Thank you so much for sharing that. It's so hard being able to balance so many different titles that you have in the hospital and outside the hospital, being a mom, being able to sort of be there for your family. And it's really great to sort of see, although it was difficult and stressful, you did it so gracefully and was able to have a village around you to help you during that time. I guess like now that you're a surgeon, you're an educator, you do all these different things. How do you still balance personal life with your professional, like basically your professional responsibilities and all of that, basically?
I don't know that it ever gets easier. And it's funny because like I can tell you two very real conversations I've had this week. One was over the weekend when I was talking to a senior mentor about that exact question. Because as
Mm,
you advance in your career, you realize you're going to have to start making choices if you want to maintain your mental health. Because my 43-year-old body is not the same as my 23-year-old body or whatever, however old I was when I was in residency. So things hit harder. I was up till midnight doing a case on Saturday. I was destroyed on Sunday. And I still had to get up and get ready for the week. And so you don't bounce back the same. So because of that, your physical limitations start to present themselves and you're like, what can I take off my plate? Do I really need to be
mm,
doing all these things? How can I make sure I'm present for my kids? And then with having children, um, you realize that you think they really need you when they're babies. Yes, they do. My kids were fed. I nursed all of them. I like whatever. But like it's when they're older that they start to say things like, why are you going to work again? Like, why, like we wish you would stay home and things like that, because they want you to talk to them about the things going on in their
hmm
lives. So because of that, her advice to me, which was very poignant and which is kind of what I'm sharing with you guys, is like at each stage, you have to ask yourself, like, what is your why? Like, why am I doing X? Why am I saying yes to this next opportunity? Why am I staying up late to work on this project? Why am I
hmm
taking this new position? So like for the leadership stuff, for me, I think it matters that we have representation in different rooms. And while I don't necessarily have an aspiration to be president of any society, I do think it's important to be on an executive committee so that your thoughts can be heard and you can weigh in and you can know what decisions are being made. While I don't need to be, the official program director, I do think it's important to be part of the screening process so you know who's getting interviewed and who's being turned down and why. And if you can
hmm
advocate for somebody, advocating for them and say, hey, I think we should look at this applicant. And then obviously, like, from a family standpoint, like adjusting my schedule. So maybe instead of being at the hospital all day on Tuesdays, like maybe I can alternate weeks so that I can be home one Tuesday a week or work from home so that I can be here when my girls get home from school and I can talk to them and things like that. So
Yeah.
while I may not have the opportunities or like case wise, like we all want to be surgeons, right? So it's a matter of you want to build your technical skills as a surgeon. So you want to say yes to every case. But if saying yes to that case means that this is a fourth night in a row that I'm not going to be home before my kids go to bed, that's not cool, you know? Or like even just now, this is a night where I'm missing bedtime per se, but to me, this matters more in this moment because my kids know that I'm going to come upstairs in 30 minutes and they're still going to be awake. But to be able to sit with you guys and chat with you about stuff that maybe you haven't heard before, or what, like to me, that matters more in this moment. So I think being reminded of that was really helpful. And allows me to kind of keep recalibrating and saying, okay, that worked for you last week. Is it still working for you this week? Is it still the right decision? And making sure that if it's not the right decision or if you're doing it for the wrong reasons, you kind of get it off your plate. And then also, the second conversation was with my 7-year-old who this afternoon told me, Mommy, when you talk to that person, you seem really upset. Da, 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 da. You seem stressed out. And I'm like, okay, the fact that my 7-year-old is picking up on my stress from this relationship says, first of all, I need to be more mindful of how I'm showing up for my kids because they're picking up my energy. And also, what is that relationship doing for me if they're giving me so much stress that my child is picking up on it? So that's when it's like getting those external checkers that help you see that something is off. So even though you
Mm.
don't realize that you're not balancing it well, someone else is picking up on it. So being humble enough to be able to be like, all right, let me listen, let me go take a seat, kind of reflect on this and see if I can do better.
Thank you so much for sharing that. It's hard. It definitely is hard, but you've been doing it so well, and a lot of people I look up to you. So thank you so
I
much for being an
appreciate that.
example for all of us.
Thank you.
Um, Now that we're at the last 5 minutes before the hour, I kind of want to give a pause, sort of allow you to give your spiel and advice that you give to your younger self, basically. So we have
Oh.
pre-medical students and medical students in the call. What would you want to tell them?
Oh goodness. I'm a firm believer that as long as you have the right intentions and you show up to the best of your ability, you're going to end up where you're supposed to be.
Mhm.
Um, my faith matters to me, obviously, and is a big driver for what I do. So those two things to me go hand in hand, right? So if you're doing something for fame, attention, recognition, to shine more than somebody else, obviously, I don't think those are the right intentions. But if you're doing them for the other reasons, and I do think that like when opportunities pass you by, when you get the rejections, when you see the failures, when things don't happen the way you would have preferred them to happen, trusting that innate sense that, like, all right, I did everything I could. I did everything I felt was the right thing to do. I've put in my blood, sweat, and tears. So now the chips are going to fall where they may, and trusting that. Not stressing about like I've spoken to people who kind of feel like they have to have everything together in line and get, meet this and da. We're all type A, I think, by default. So we're all going to work hard. It's a matter
Mhm.
of like checking yourself and saying, okay, why am I doing this to check the boxes or am I doing this because this is really what I'm being called to do? Um, and I think, you know, kind of allowing that to be the thing that brings you peace at the end of the day, because you're always going to be someone who's smarter. You're always going to have that gunner co-med student that's like, oh, that test was easy, and it probably wasn't, but they're trying to get in your head, and you have to be like, you know what, I'm doing the best I can, and that's what matters. So I think it's like finding that thing that really is your specific passion calling. Am I giving it my all and doing the best that I
Mhm.
can with it, and then trusting that the rest will work itself out? So with everything from the match to, your partner relationships or things that may work out or not work out, to exams going well or not going well, like if you can answer that question honestly, then I think it should hopefully provide you some peace at the end of the day.
Thank you so much for sharing your words of wisdom tonight. I think the common thread that I was able to gather from all the things that we discussed today is just me being able to move with intentionality and authenticity and being passionate about the communities that you're wanting to serve.
Yeah.
So thank you so much for being so transparent and sharing your story. I learned a lot just hearing you speak. I know a lot of people message me privately, learning so much from you as well. So we really appreciate your time this evening and for being able to share the great insight that you have and look forward to sort of building that relationship as we move forward with the TSMA and all the great things that you're doing. So thank you
My
so much, Dr.
pleasure.
Wilder.
Great to
Yeah,
meet you and work with you, and nice to kind of see all of you from afar. I look forward to meeting you in person.
absolutely. Well, I hope you have a wonderful night. Enjoy time with your kids.
You
Um,
too.